everybody. Dr. Shane Steadman with Integrated Health Systems. We are going to share the three signs that you might have post-concussive autonomic dysfunction. So we're going to spend the next 40 to 45 minutes going through that and giving you all some information that hopefully is helpful, and then some things to think about, look at, and I'll answer some of these questions that you all have. So I got the chat box up and running so that you can ask some questions, and I will try to answer them as we go through this. And also, I have this recorded, so we will be able to send this out. If you're looking to listen to this again, share it with others. That's what it's going to be there for. So we do this all for you all, and hopefully we can, look to help more people as we go along. So this is a very interesting topic that we're going to talk about. So if you're not familiar with me, my name is Dr. Shane Steadman. I'm the owner of Integrated Health Systems and Integrated Brain Centers here in Colorado. And I'm going to put people on mute as we go along. So if you guys can all remember, just put yourself on mute so that we don't get some crazy feedback, but we can definitely take questions as we go along. So I'm in Denver, Colorado. We have Integrated Brain Centers and we have Integrated Health Systems. And really kind of our practice, we combine this functional medicine and functional neurology with just about every single patient that comes into the office. So it just really helps us to get an idea of what's going on and really trying to get to the bottom of it. So it can get really difficult with some of these cases, but we definitely have more of a team approach. We have a nurse practitioner, nutritionist, Dr. Maynard, myself. We have therapy assistants, and it's kind of an all hands on deck. So we learn a lot as we go along. And I think this is actually one of those topics that we are continuing to learn. And we have really learned a lot. We're really implementing over this past year and a half. And so we've been really talking about dysautonomias and autonomic dysfunction. So we want to kind of talk about that a little bit more. If you're wanting to learn more about dysautonomias and kind of the terminology and things like POTS, there's actually a great webinar that Dr. Maynard did discussing that. And he did a really, really good job. Sometimes that's a really confusing topic. But he really tried to break that down. So today we're going to talk more about post-concussive dysautonomia and autonomic dysfunction, and kind of what we're looking at and some of the things that maybe you guys can all do and look at yourself. So again, so I've been doing this for about 19 years. It's a long time. It's kind of fun. All right. So we're going to look, and I'm going to move this chat around a little bit so that I can see my notes. But when we look at autonomic function, and I think that's kind of a big term, what I find fascinating is that, over the years of doing neurology, we talk about the central nervous system, or the CNS, and that's looking at brain and spinal cord. We look at the peripheral nervous system, which is the PNS, and that looks at your peripheral nerves, like your sciatica. That's a peripheral nerve system. But one of them I think that's definitely gotten left behind is the autonomic nervous system, or the ANS. And this is something that we've really been kind of bringing to life, I think, in the practice. And it's kind of been a big aha over these past couple of years, that I think as a community in the healthcare community, I think we're really not talking about the ANS system as much, or the autonomic system. And I think we talk about a little bit from a fight or flight system, but honestly, I think even if I look back over my years, I wish the information that we have now I could have had a long time ago. And I think that's always true. As you get to learn more, and as you grow, and as technology evolves, you always wish you can kind of go back in time and maybe help some more people that now we have the tools to do so. So let's talk about autonomic function first, because we got to kind of understand, what does it do? And then how does it come into play when we start looking at concussions? So your autonomic system, as I kind of mentioned here, that's your heart rate. So we can look at rate and we can look at rhythm. So when we look at arrhythmias or tachycardia, which is an increase in heart rate, or bradycardia, which is a decrease in heart rate, those are some of the aspects of how our autonomics affect that. And we know this, right? So when we go, in Colorado, we go up in altitude. I was up in the mountains last weekend, and just going up in the mountains, you feel your heart rate kind of kick up a little bit when you're at those altitudes, because you're compensating. And so your whole autonomic system says, I got you, so that you can go do the things that you love. So other things that are involved is breathing, blood pressure, but I think we all forget about things like digestion. So in the functional medicine space, we're always talking about digestion and leaky gut, and this is all true. But if your autonomic system is not working, how do you get blood flow to your digestive system? How do you get nutrients? And that can really impact digestion. So your whole autonomic system can really affect digestion, bowel and bladder, absorption, even other organ systems. You've got to have blood flow to them. So our autonomic system is really important for a lot of these digestive pieces that they really just don't talk about in neurology. And then we look at eyes, right? So we look at our pupils and how they dilate or they constrict to increase light or decrease light. If we're in the dark, our autonomic system will increase our pupil dilation so that we can get as much light in as possible. That's why you kind of hear these terms like white as a ghost. It's like when you kind of lose that blood flow, when you get scared and your pupils dilate, we say, okay, how's their autonomics? Mouth, we talk about dry mouth. You see this when people get older, they start to have dry mouth. A lot of patients, they'll bring in water and they're constantly sipping it because their mouth is so dry. But you can have other functions of maybe too much saliva production. Maybe you have a gag response that's decreased. You have a vagus nerve that's not working the way it's supposed to. Those are all autonomic system functions. So this is, I kind of say this over and over again because I think overall the vast majority of us don't really quite understand how big the autonomic nervous system is and how much it controls. So when you're sleeping at night, and all those things are working without your consciousness, that's your autonomic system. When you get scared, that's your autonomic nervous system. And so we look at the last two kind of big competing forces in the autonomic system, and that's your fight, flight, or freeze, or the opposite is your rest and digest. And so we need both of them. They're both important at certain times. And really, when we talk about this dysautonomia or autonomic dysfunction, is we really start to understand the imbalance or this tug of war between this fight or flight and rest and digest system, or we say the sympathetic system and your parasympathetic system. So kind of that's your kind of overview. So when we look at concussions, we're going to really kind of see how that really comes into play. So I put in this slide because I think it's kind of another thing to say visually. Let's look to see what's going on. So your sympathetics, can reduce things like saliva flow, increase your heart rate, vasoconstriction. So when you see like people with cold hands and cold feet, that can also be an autonomic issue. Today I was actually working on a patient and, I was doing some things to stimulate her pupils, and all of a sudden her hands got super clammy and she's like, oh, my hands feel weird. They're getting really clammy and cold. And I was like, oh, so we definitely, increased your sympathetic response. But you can look there too, is like when you're in a sympathetic position or mode, it reduces peristalsis. So it reduces the mobility of your intestinal system. So sympathetic response can cause constipation. Now, which I think fascinating about looking at autonomics is that when we talk about IBS, nobody really talks about brain function in IBS. We always talk about, intestinal bacterial overgrowth, and we talk about SIBO, we talk about food allergies and leaky gut, but we don't talk about the brain. But if you have abnormal autonomics, then you can actually have constipation. You can have a change in glucose production from glycogen, which is in your liver. So, when you're going in between meals, you need a system to say, I got you covered. I can pull glucose out of the liver for store, out of storage for fuel. This is the same at night. So you've got to have great autonomic function while you're sleeping so that your body can do what it needs to get through. And when it can't, that's when you start seeing people like waking up in the middle of the night. And some people wake up 2, 3, and 4 times because their whole system is so out of whack that it can't regulate itself while you're trying to get a good night's sleep. And so on that parasympathetic side, you'll see over there that, it can stimulate blood or saliva flow. It can decrease your heart rate. It can help with breathing, peristalsis, bile release, bladder contraction, all those different things. It's a lot. And that's what I think has kind of been fun over these past couple of years, is really to understand how this all comes together when we look at concussions. So when we talk about signs and symptoms of dysautonomia or autonomic dysfunction, these are some of the big things that we see in practice that I kind of want to point out. And I would say headaches is probably one of the biggest things. Headaches, they could be pressure in the head. It can be kind of that pounding sensation. People have talked about even hearing their heart rate, just like that pounding, throbbing sensation in their head. We definitely see this with exercise too, going up and down stairs, exercising, moving, because when you go up and down stairs and you exercise, you have to use that autonomic system. And if it's dysregulated, then all of a sudden you get this pounding that's in your head. Nausea is probably another big one. Working with a patient right now that has nausea every day. She has a dysautonomia that's creating this nausea every single day, and that's kind of, we get into the lower brainstem, and I'll kind of point that out here in a bit. But when we get into that lower brainstem, that's where we kind of start seeing some of that vagal tone or the vagus nerve that's not working as well as it should, and that can cause nausea. Tachycardia, which we talked about, but we see that a lot, especially when people change positions. Their heart rate will go really fast, and they'll feel their heart start beating in their chest, or they'll start hearing it in their head. Breathing difficulties, temperature regulation. These are probably two big ones: the sensitivity to light and sound. And when we get to another picture, I'm gonna kind of break down the brainstem a little bit and show you, because I think when we get into concussions, these are some of the bigger areas that we start seeing as players and people, and what people are experiencing. You can also have aches and pains, and then we can have GI complaints. All right, so let's talk about three signs, because we wanted to talk about that today. Let's talk about three signs, but obviously I'll probably go on tangents. If you listen to me before, I tend to go off on a tangent, and I'll come right back. So let's talk about headaches. So headaches is probably, like I said, probably one of the number one symptoms of a post-concussive dysautonomia. And it's really interesting because I think there's been a lot of times over the years where we actually do a lot of brain rehab, and we can get a TBI, start to finish, like doing really well, but these headaches tend to linger. And I think when we look at some of the dysautonomia and autonomics, it gets a little bit tough sometimes to regulate those, and there's some really cool ways of doing it. But I would say some of these headaches are some of the harder things to fix in TBIs, because they just tend to linger and linger and linger. Even after we get people's brain injuries, doing much, much, much better. And I think kind of what we've been learning over the years with autonomics has kind of been a game changer. So when we look at headaches, some of the things that we're trying to figure out here is, we look at head pressure, and we have these baroreceptors that are in our neck, and they're inside the carotid arteries. And these baroreceptors, what they do is they dictate, how's the blood flow to the brain, because we don't want too much pressure in the brain, or you can create hemorrhagic stroke. But we don't need little pressure to the brain, because we need to have oxygen. So these sensors in our carotid arteries, the baroreceptors, they help us to dictate where we at and what our position is, how much pressure do we need to the brain to maintain blood flow. And so when those pressures become abnormal, then that's when we start seeing headaches come into play. And so we can see headaches from not enough blood flow, too much blood flow, changes in pressure. That's where these headaches start to come into play. And you hear people talking about this all the time. I got another patient, she was in a car accident, and when she puts her head down kind of below her knees, her head starts to pound, and she even says it feels like her head's going to explode, and there's like a splitting headache. And then when she comes back up, it lingers for about a few minutes and then starts to go away, but she can't do anything where there's like this bending. So we're working on that. Or we have another patient that when she goes from like sitting to standing, she feels like, her head's going to split and kind of explode, as they all say. So a lot of times when we're looking at headaches, those baroreceptors that are in the neck actually become some of the bigger things that we're looking at. But there's so many factors of blood flow that go on within the brain, and that's kind of when you see a lot of these headaches really taking place. So I want to show you this, and I actually got this kind of popped up a few times in the slides, but it's kind of a cool illustration, because what we're looking at is the brainstem. Now we're going to break up the brainstem into like three different pieces. The bottom piece that you see, where it kind of says like hypoglossal nerve, vagus nerve, and all those with like the little nerves coming off of the bottom, that's the medulla area. And so that's kind of the lower third of the brainstem. And that part of the brainstem is where we see like the vagus nerve. So when we look at like vagal nerve function, they say like vagal tone. If you get fancy, it's the dorsal motor nucleus. It's kind of that lower part of the brainstem. A lot of people say that's kind of more like the parasympathetic part of the brainstem because it helps with rest and digest. It helps with motility and things like that. So you kind of hear like different terms. Now, that middle part is the pons area. And the pons is we always kind of laugh in neurology because a really easy way to remember the nerves that come out of it is there's a little saying 5, 6, 7, 8. Who do we appreciate? The pons. So those nerves that 5, 6, 7, 8 they come out of there. But what's really important about that pons area, well, I'll back up a little bit. When we look at 5 and 6 and 7 and 8, those are actually really important nerves because when you the nerves that are in the brainstem they can be grouped together for certain functions, or they can have like individual functions. So for instance, if we look at cranial nerves 5, 7, and 8, those actually are really important when we look at like cardiovagal tone, or we look at heart rate and rhythm. So that part of the brainstem comes out to tell your heart, okay, this is what we need to be doing. But then you look at like cranial nerve 8, and that's your vestibular nerve. So we say, whoa, so the vestibular system can have a huge part of like heart rate. Well, that makes sense because if you're ever on a roller coaster, right, and you're like doing twirls and loops and spins and all these things like that, over time you start to get nauseous, right? You start to like your mouth starts to water, you start to get nauseous, your stomach gets upset, and if you don't stop and your brainstem gets stimulated over and over and over again, you can actually vomit. So it's kind of cool in a weird way is to say like look at what this like vestibular nerve can do into that whole pons area. But when you light up that brainstem, you start to light up everything. And that's why you see when people are going to throw up, their mouth starts to water, their stomach gets upset, their eyes start to water, their face gets flushed, because you're getting this massive autonomic function that's all through that brainstem. So it kind of tells you how important this brainstem is. Now, the upper part of that brainstem is kind of involved in a lot of our fight or flight system. And so when we look at headaches, actually some of your headaches, or a lot of these headaches can actually happen in that upper third. And so we're going to kind of talk a little bit more about that little spot on there called the colliculi. This is where we start seeing some of the sensitivities. And this makes sense because when people have headaches, and actually we'll go into it. So if you kind of look on that diagram there, there's what they call the superior and the inferior colliculus or colliculi. And those colliculi, they allow for light and sound to come in, and that kind of helps you to know where things are at. So when you kind of watch these scary movies, and there's the pin drop or the water drips, or there's like a noise, that's those colliculi. They get activated. So if you go into downtown, they're hyper vigilant, like, where are things at? And is there a shadow? Is there movement? Do I hear a noise? And those are like those fight or flight mechanisms say, hey, we got to stay safe. We have to stay safe. Well, when people have headaches and migraines, it's usually found in that kind of same area, that upper brainstem. And this is why like light and sound becomes so noxious. And a lot of people that with migraines, they go into a cave, they go into a dark room, they put headphones on, earplugs, they try to get away from light and sound because it just fires up that system. Now we see the same thing in brain injuries. A lot of brain injuries come in and they talk about they've been living in their bedroom with the blinds shut and the door closed, because their brain is such in that fight or flight mode that light and sound just activates it, and they got to get away from it. So when we look at headaches as being one of the number one things that we see, it starts to make sense because this whole brainstem can be really involved in that, and all these like autonomic systems really get involved in the arteries and how they dilate, and the trigeminal system, and those like migraine patterns that people feel. So those are some of the more common things that we see. So it kind of brings us to number 2, which is light sensitivity. And light sensitivity kind of goes back to what I was discussing with those colliculi. So that superior colliculus actually is what kind of brings light in. And so we see a lot of times when people have these post-concussive dysautonomias, we actually turned the lights off quite a bit. In all our rooms we have dimmers, and you can almost tell when somebody has a post-concussive like this, autonomic dysfunction, because they're flipping the lights off, they're dimming them back down. We even have patients that come in sunglasses because the light is so strong, even a little bit of light, that they can't handle it. We got a patient right now that was had a brain injury, and his light and sound is pretty intense. So he came into the office with headphones on and sunglasses, and then he turned off all the lights and he shut the blinds. And so that's how we started the exam. And this was about 2 months ago or so, and now he's doing better. We actually have him in rooms. He doesn't have his sunglasses on or his headphones off, but there's certain rooms that have the air conditioning that kind of drives him a little bit, batty with the sound. So we always go to one specific room as we're working on him. But you see this a lot. So kind of going back to that brainstem, we're looking at that upper brainstem. So as you're increasing light and sound, it fires up that whole like sympathetic system, and then that starts changing blood vessels and blood flow and circulation and even gut function. You see a lot of times when people are stressed, they have a lot of gut issues. If they have anxiety, they have gut issues. There's so much connectivity that goes on within that whole brainstem and in the gut when it gets into stress. So to back it up, so with light sensitivity, you tend to see some of these other symptoms too, like anxiety tends to be a big factor because you have your limbic system that's kind of sitting close by. And then sleep becomes a really struggle for a lot of people, because when that brain gets fired up and that sympathetic system gets fired up, you have your like sleep wake system that's in there too. And so it makes it really hard for people to go to sleep or stay asleep, which if any of you have had brain injuries, that just starts to perpetuate itself, and that becomes a really vicious cycle. So the light sensitivity becomes really big. And when people have anxiety, we see very often their hands are very clammy. Their reflexes are very sensitive. Their whole body is sensitive. It's sensitive to touch. It's sensitive to sound. It's sensitive to like even being in a close proximity. Your body wants to go into like a withdrawal response where it's like trying to pull away. And so this is when you start seeing light sensitivity, that usually tells you that upper part of that brainstem is firing at a pretty good rate. And when that system is firing, then it just really disrupts the whole entire autonomic system. All right. And then heart rate. So this is probably like the number 3 thing that I kind of want to chat about is heart rate. And this is kind of what we start seeing when we get into like POTS. So POTS is a postural orthostatic tachycardia syndrome. And I would say very, very, very common when we see, TBIs, post-concussive syndromes, that a lot of times we see these abnormal heart rates. And I gave you a couple of graphs of things that we're kind of seeing, which is really, really kind of cool to be able to map these things out. But we see abnormal heart rates with postural changes. So if somebody goes from lying down to seated to standing, their heart rate will tend to just skyrocket. If people go to the gym, their heart rate just goes straight up. My daughter had a concussion playing soccer several years ago, and just going up the few flights of stairs, her head would just start pounding, her heart rate would go up. So you see this is a very, very, very common thing. Now, if the heart rate goes up, there's usually a reason why. And this is where we get into definitely looking at autonomic function, because if your heart is compensating, then the question is, what is it compensating for, right? If your blood pressure drops, then your heart rate will compensate. If you're not getting good blood flow, your heart rate will compensate. So your heart rate tends to be this very interesting compensatory mechanism that we're kind of like, thank you for being there, but we feel it in our chest, we feel it in our throat, we feel it in our head, but it really tells you there's other things going on. But heart rate kind of becomes one of those things that people very often talk about. Now, this can go hand in hand with things like dizziness, cold hands and cold feet, or even low blood pressure. So when you kind of hear the term like POTS, which is a really, really common term at the moment, with the postural orthostatic tachycardia syndrome, this means that when you change a position, your blood pressure drops and then your heart rate compensates and it'll shoot up on you. And we'll see people shoot up into 130, 140, because now you get to a position where your brain has to like figure out and try to modulate and control what's going on, But if you have a brain injury, you lose these control mechanisms. So now things are firing abnormally. They're too fast, they're too slow, they're inappropriate, the wrong times, and it makes it really hard to do life sometimes. So, so we look at kind of these three big things is like if you're struggling with, headaches and light sensitivity and these alterations or changes in heart rate, those are really common symptoms that we see with concussions, but they're things that they can fix. But then that tells you that we're dealing with an autonomic dysfunction. And that's where I think, and I love the functional medicine space. I lecture in it. I know tons of people in that world, but I think this is sometimes when people go, oh, we have gut dysfunction, then we got to do supplements. We got to do a dietary change. We got to work on leaky gut. We got to work on this. We got to work on that. And that makes sense, but that's not the problem. So the problem is that their autonomic nervous system is not working. Same thing with chiropractic. I love chiropractic. We're chiropractic neurologists, and you see the same thing. We're like, I just got to adjust you. I got to adjust you. I got to adjust you. I got to do massage. I got to do craniosacral. I got to do this. I got to do that. Those things could be awesome, but we're still not getting down to why is your autonomic system not working. And that's where I really want to impress upon people listening is like we got to find these docs that are really good at identifying dysautonomias and autonomic dysfunction and how to fix it, because that's where you start seeing these changes. Now, definitely working on brain function can really be supportive, but again, there's three different pieces of the nervous system we talked about: the CNS and the peripheral nervous system, the PNS, and then the autonomic or the ANS. So we've talked about three pieces. So to identify each of those three, I think is a really important piece for getting back from a concussion. And so I know there's a lot of people that listen to these webinars, and they pass them along, and that's great. I think if we can identify that we have three systems that we need to work on, then I think that will hopefully start helping people to get to that point. I was talking to a patient yesterday, and I kind of mapped it out on a whiteboard. So, we have whiteboards in all our offices. So I was trying to map out like, here's how this system and it integrates with this system. And he was just like, oh, because I love the fact that he likes trying things, but he's going to this therapist and this doctor and this provider and trying craniosacral and massage and this and all that stuff is fantastic. But you get to a point where you're just trying everything and hoping for the best. And sometimes it works and a lot of times it doesn't. So if we can say, well, what about this autonomic piece? How can we identify that? I think that's where we can see some really cool things taking place. So I want to kind of show you this. This is kind of cool, and this is some of the things that we actually are diving into lately. But we're actually able to start kind of graphing and mapping out kind of autonomic function. So this is actually one of a patient that's fairly normal. So kind of tell you, so the top the blue line is our blood pressure, and the bottom red is our heart rate. And so if you kind of look, so kind of at the beginning of this, what we do is actually hooking up EKG leads. We're hooking up 3 blood pressure cuffs and leads. We're hooking up oxygen saturation pulse oxes on 3 different limbs. So we have them on a tilt table. So we're actually bringing them through different positions and having them do different things while we're mapping this out for a patient and seeing what it failed. And so with that, so what we're kind of looking at is, we say, okay, here's normal. And it's kind of nice to see. So we have, our blood pressure that's, up there above 110, which is good. And we have our heart rate, which is down. And then as we kind of go through like these shaded areas, one of the shaded areas we're looking at like a deep breathing, and then we look at a Valsalva, and then like the yellow is the tilt table, and then the last one we're looking at a hand grip. So we're looking at different autonomic pieces and then seeing what they do, and kind of what I want to show is that what's really kind of cool about mapping some of these things out is we can see where the heart rate goes up when like somebody's on a tilt table, but their blood pressure started to come down. When we do it a hand grip, that actually looked pretty good. Deep breathing looked pretty good. But I'm going to kind of show you what one of a patient that you go, oh, that's not so great. So this is kind of a patient that has some dysautonomia. So what's really kind of interesting, like on the tilt table, for instance, when we put her on the tilt table and we start bringing her into gravity, we see right away that that blood pressure just goes down. So the blue line goes down, and then the heart rate, or the red, goes up. And so she's, probably pushing about 130, 140 at certain times. So which tells us like that's not a good response. So her autonomic system isn't able to just manage a simple like elevation or a tilt. And we have one of those cranks. So we're just cranking slowly and bringing a person into an upright position. And what we find is her whole autonomic system says, I can't do it. And it just falls apart. And it's really interesting because even like bringing somebody up, people talk about, headaches and sensitivities. We had a patient almost like went into like a syncope where her body was just like, I can't do it. And she almost fainted, which, we all sit there and monitor, and they're kind of like, they got a belt on them, just make sure they're safe. But it was like really fascinating to go, whoa, that's not good. And we literally saw the blood pressure go all the way down to like 70 over 40, and the heart rate kicked all the way up to 138. And so it's these little pieces that you go, ooh, this is not good. And so I'm kind of pointing this out because this is something that I think if you guys who are out there say, okay, we got to find docs who are educated on this, but this could be a piece of the puzzle that really hasn't been looked at yet. And so this whole autonomic nervous system is a really important system that we want to keep on top of. And so I think what you're looking at too, as we're looking for practitioners, and if you guys need our help, and we're always open to help find. There's definitely some really great practitioners around the country, but so I think it's really important to make sure you find somebody who's going to actually take the time. I was talking with a lady today that she has Tourette's, and so I was just telling her basically this. I'm like, she's like, "What are you going to do?" And I said, "We're going to collect data. We're going to do a person. We're going to look at your history. We're going to look at the mental health side. We're going to look at what happened. When did this happen? We're going to really like dive into the health history piece, and then we're going to look at things like blood work, and we're going to look at labs. We're going to look at testing that you've had done, MRI, CT scans, images, and then we're going to do like a detailed exam where we look at the neurological piece and the orthopedic piece and the autonomic nervous system. And, we're going to pull all this together and say, here's what's going on with you and where we're going to start. And she's like, why didn't everybody do that? It's like, I don't know, but there are people who do this. So, if we need help finding people in your neck of the woods, we're definitely going to help. So I think these are some of the things that I say for you guys to make sure, go look for these people. A lot of times you'll kind of see more in that functional neurology world. So if you kind of look up like functional neurologists near me, that's kind of a great place because a lot of those docs do. But I think this is even kind of a growing section of rehab that we're starting to see more and more that's taking place out there. So the current management, this is what's interesting. So I kind of threw this in there because I think where a lot of patients that we're seeing are getting frustrated is like when you look at like a dysautonomia or POTS, kind of the current management of that is really centered around here's some exercise and here's some salt. And the salt helps to bring the blood pressure up, but like that's kind of a symptom-based relief. Like if we're what it should the management be? And it's like if we're looking at what's going on with the patient, if they have like a brainstem imbalance, because if we go back to, and I'll kind of skip pretty quick over the picture, but that brainstem, if you kind of envision that that's the stem and you have your brain that's on top, and when people have concussions, you can get a shear that takes place, and they actually look at this on imaging and some of these really cool images that they do out there, but they can kind of look at this shear that goes on between the brainstem and the brain. And so that shearing response, whether you have like a whiplash injury or you have a sports injury where you're looking one direction, your body gets hit another direction. These types of concussions, they really impact this whole brainstem. So then the question is like, how well are people looking and evaluating the brainstem or rehabbing it appropriately? I would say another place that we've found a lot of dysfunction is looking at vestibular function. Because we all know that if you're on a roller coaster, you can get sweaty, clammy, and nauseous, right? But if your brain and your vestibular system is constantly not synced together and there's a mismatch within the systems, then it's almost like your brain says, I'm on a roller coaster every day. And so now you get this constant nausea, you get this constant clamminess that can take place because the signals that are coming in are not appropriate or they're not synchronized. And so now you get this abnormal bombardment of sensory information into that brainstem. And so it doesn't quite know what to do. You even see sometimes when people have vestibular issues that they can have a lot of like angst or anxiety because their body's like, I don't know where we're at in space. I don't know what to do with this. I don't know what is going on. And so it starts to create this sympathetic, like anxiousness. Even a patient we're working with right now today, she has a lot of vestibular issues. She's got clammy hands and she's got some anxiety and sleep issues. And you go, okay, this is starting to make sense. So as she's doing better, her hands were quite a bit drier. Her eyes actually looked better. Last night she said she only woke up once, so we're going to see how she wakes up tonight. But, we're starting to see some changes already in her autonomics because she was able to wake up one time at night. So she said about 3 to 4 times every night. So it's like, okay, if we can reproduce that, then that's totally awesome. But this is that part of that brain that we need to like say, okay, what's going on in this area that's not able to regulate? Or we can even take a step further and say, what's going on with the cortex or the frontal lobe that it can't send down things to control the brainstem as well as it should. So I think this is kind of why I named the practice integrated brain center. Everything is so integrated. And I think that's what makes it hard when you're trying to do brain rehab. But if you understand the different integrations, it definitely gets easier and easier, but it's a hard system. And I think that's why a lot of people struggle. All right. So if we kind of go back, I think the last thing that I kind of wanted to point out was, there's metabolic areas that we have to look at too. I think a lot of times, I think some of the neurologists get so caught up in the brain that they do miss out on what are other things that we need to be looking at. Because, if we start looking at stress, right, or a sympathetic response, there are things that can affect your sympathetics. Inflammation is one, and where does inflammation come from? That could be stress, that could be a lack of sleep, that could be a chemical exposure, that can even be food. So there was a brain injury group that I went to once, and I remember they had pizza in the back table, and I was like, really, pizza for a brain injury group? And it's just like you don't think about it, but then if you stop and think, you go, oh, that can't be great, right? We're gonna have this inflammatory food for a bunch of brain injury, people that are suffering from brain injuries. So we even talk with our patients and say, hey, we need to make sure you're eating well. We need to make sure the inflammation's down. It's probably not great to have, processed foods that you can't even pronounce the name and your brain is, inflamed. Another piece that I think is important that gets overlooked is blood sugar, especially when people feel nauseous. So when you have a lot of nausea, that's probably the last thing you want to do is eat. So a lot of times your blood sugar tends to go down with a lot of patients. So we have to constantly say, hey, we need you to eat. We need some protein. We need to make sure that you're providing fuel into the body because that's how neurotransmitters are made. Serotonin is, there's a huge insulin component to serotonin. There's a huge blood sugar component to GABA. We know that GABA helps to calm down the brain. We know that serotonin can help with mood, and serotonin converts to melatonin for sleep. So if you're having these abnormal blood sugar or food issues, that can really mess up 2 neurotransmitters in your brain, and then you can start having symptoms that way. So then you're trying to figure out, is this post-concussive or is it because you're not eating enough? And so I really say it's important that these are things that you guys can do that you don't need a doctor's. We can say, what things can we cut out that are inflammatory? Can we eat better? Can we keep our blood sugar stable? And then when we talk about adrenals, we look at stress response, are you doing things? And I know it's easier said than done, but, are there things that you're doing to do self-care? Self-care is a very, very important piece, but I think it's one of the hardest things for us to all do. It feels very selfish. Some of us don't know how to do it. Some of us don't have time, but these are areas that we have to kind of work on when we have brain injuries, because if you have this tug of war between sympathetics and parasympathetics and you're constantly stressed, that doesn't help the cause. It makes it tough. And so there's things that we try because we have in our control, and there's things that we know that are out of our control. And so, this is part of that healing process that, it's not easy. So, you can try to make it easy, but it can be really, really tough. Right. So kind of wrapping this up, I think, there's a lot of things. So, we're going to keep talking about dysautonomia kind of coming out of our clinic. So, stay tuned and we're going to keep talking. Like I said, Dr. Maynard has already done a few of these looking at different aspects of autonomics and dysautonomia. This one we wanted to cover more of like kind of the concussion part of dysautonomia because I think people don't think about that. I think especially right now in our world, you kind of see everything's related to like mold or mast cell, and that's not everything, and I think the concussion side of it kind of gets left behind. But if we start looking at concussion as a whole and think, hey, there's three different systems we need to evaluate, then we start to pull those pieces together and it makes our treatment plan a little bit more comprehensive or a little bit more even specific to say, hey, we're going to target this part of the brain that's responsible for the dysautonomia, and we're going to make it stronger so they can regulate their autonomics, and that can really fall down to better sleep, better GI function, gut motility, bowel, bladder, sexual function, breathing, exercise. All those things start to come into play. So it's always good to get on, work on this quick and find somebody because there's stuff that can be done. And I always put on there, it's never too late, because I get asked this all the time. I've been doing this for 10 years. Is there stuff that we can do? Absolutely. We've worked on people that are 25, 30 years out from a brain injury and still made some changes. Does it get a little bit harder? Possibly, but it's never too late. There can always be things because your brain is plastic. It likes to change. So I think as long as you're inducing plasticity and you're creating change and positive change, it's never too late. So I never, ever believe that's too late. There's always something you can do. And, and like always, if you guys are interested in what we do, want to find more out, see if you're a good fit, we always do free 30-minute consultations because it has to be a great fit. There's a lot of work that everybody puts into this, and we want to make sure that, that we're matching as best as we can. And, we're here to serve. We want you guys to be well, but if you guys need to find somebody that's closer to you, that's a great thing too. There's some brilliant, amazing docs out there doing some great things, and we're happy to help in any way we can for everybody. So, let's say telehealth is available. So, I mean, we do some of that. It's harder. It's funny. I'm like looking at the screen going, yeah, we have the screen in there, but yeah, it gets a little bit harder when you get into brain injuries. But, we actually do, some telehealth where we can work with people and do certain things. But on the brain injury side, you definitely have to get your hands on people. But yeah, we can do video conference calls and video consultations if you're ever interested. So if you are interested, so you call it, we always do free 30-minute consultations. So there's our number. Again, you can visit us at Integrated Health Systems, Integrated Brain Centers. We're in Denver, Colorado. It's beautiful all the time. But I kind of been watching the chat messages. Hasn't been a lot of chats, which is, I guess, maybe I'm doing a good job. I don't know. But if you guys have some questions, I'm definitely happy to answer a couple things. And then I want to make sure that you guys all have an awesome, rest of your day as well. Jeez. Ooh, that's it. I think that's a good question on the Buffalo treadmill test. That's been so long since I've looked into that and done that. That's a great question. I don't know the answer on the Buffalo treadmill test. I know when you get into stress tests and things like that. I mean, I think they give you ideas, but I think so often they're looking at cardiac function. I think when we're looking at ANS testing, I think I don't know. That's a good question. That's a good question that I need to probably go back and do some more reading on. Reading the next one. All right, so I'm just reading the message. Yeah, so reading the next one. This is interesting. Provider in North Carolina. Maybe type for me, Jessica, which part of North Carolina you're in. Actually, there's some people out there. Yeah, I think this is actually sometimes the struggle when you have post concussive autonomic dysfunction like POTS. You can get it under control. I think the problem is something, sometimes things can hit you like a virus. And actually you see a lot of this, by the way. I think with, kind of what's been going on in our world, I think the amount of POTS and dysautonomia we see is just pretty much unreal at the moment. I feel like that's all we're doing. Sometimes I feel bad for my nutritionist because she's like, where's all my patients? Because everybody seems to be dysautonomia from, different viruses and whatnot. So yeah, I think that it's kind of a bummer when you have POTS, you're doing better, and then you get a respiratory virus And I think what happens with those is like, yeah, then you decrease oxygen, right? And so as soon as you decrease oxygen, then your whole autonomic system has to like kick in, and it has to adjust and compensate, and it throws everything off again. And I think those are some of the things that we've definitely been working on a lot with over the past couple of years, is looking at different viruses. Even right now, there's kind of been a big viral uptick in just flu season and whatnot. And it seems like it's definitely kind of kicked up a lot of dysautonomias that are out there. So yeah, I agree. I think that's really tough. So yeah, let me see. I'll scroll down to see if you found something. Oh, Riley. So Riley. Let me look real quick. So Riley, North Carolina. Maybe look up. I'll say. So Alicia Brown. I don't know if she's. I forget how close she is to the Raleigh area. If you can make it out, you know who's really good. He's in Asheville. I'm not too sure how far you are, but Dr. Trayford is out in Asheville. He's just brilliant all around. Super smart guy. There's also another clinic. I'll pull it up. Let me pull up on my phone really quick. I just got to get their clinic name, and I can give that to you. 2 seconds. Hold on. Yeah, so there's another one. It's like Carolina Functional Neurology Center. I'm trying to see where they're at. They're the 2 docs in there. They're pretty awesome as well. They have a Raleigh clinic. So I would say go to like CFNC. So it's Carolina Functional Neurology Center, or CFNC.com. And I can type that out really quick for you too. But they're great docs out there that should be able to help you as well. Not having dysautonomia, or no concussion and dysautonomia. Yeah, that actually we see. I mean, there's actually, you can have dysautonomia from a lot of things. So you can have dysautonomia that's autoimmune based. You can have dysautonomia from Lyme disease, mast cell, mold, viruses. Even some of the we've seen some like dysautonomias just from the vaccine, stuff that's out there too. Like you can literally have it from so many different sources. So yeah, you can definitely still help with dysautonomia. It doesn't have to be a concussion. Concussion is just one thing that can cause dysautonomia, where dysautonomia can be so many things can cause it. So yeah, so definitely we can help out with that, because I think that's what our whole practice is turning into, which has kind of been interesting for the past couple of years. And it's been a lot of fun, but like I said, I think that's why we're kind of doing these webinars, because we're learning so much, and we've learned so much that we want to kind of bring it to you guys and say, hey, there's some really cool things that are out there that I think a lot of people are not looking for. But yeah, so yeah, you're welcome, Jessica. Yeah, those ladies as CFNC, they're pretty awesome people, so you should like them. But if there's anybody that's ever close to Asheville, Trayford he's a brilliant doc. So there's some really good docs out in the North Carolina area. Cool. Anything else? You guys have been great. Like I said, we'll have the recording out. So I know a lot of people get the recordings or weren't able to make it today, so we'll try to get those sent out. If you want them, just shoot us an email. We'll definitely get them to you. I think if you guys are good, I'm good. So yeah, so thanks for so let's see if there's any more questions. We're going once, going twice. All right. All right, y'all. I'll turn off the recording, and I hope you guys all have a great time. Let us know if you need anything, have questions, or we can help in any way. And thanks for being on. It was awesome to spend my last hour with you guys. So have a great rest of your day, and hopefully we'll talk soon. Stay tuned for the next one.